tunaunga mkono,
chap chap, tunaunga mkono jumuiya ya madola hapa Londoni. Oge chap chap, tunaunga mkono, chap chap, tunaunga mkono jumuiya ya madola hapa Londoni. Tunakia kujivunia utamaduni wetu wa Tanzania. Tunakia kujivunia muziki wetu kweli wa Tanzania, na nyimbo zetu kweli za Tanzania, na siasa yetu kweli ya Tanzania, na maisha yetu hayo ya Tanzania. Tunakia kujivunia muziki wetu kweli wa Tanzania. tuna haki ya kujivunia utamaduni wetu wa Tanzania. Hii tuna haki ya kujivunia muziki wetu kweli wa Tanzania, na nyimbo zetu kweli za Tanzania, na siasa yetu kweli ya Tanzania, na maisha yetu hayo ya Tanzania. Hii tuna haki ya kujivunia muziki wetu kweli wa Tanzania. Halo. Nikukwenda nyako. Ale. Wote watu wa Bagamoyo tunawasalimu wasanii wenzetu jamani. Mimi zao tunaimba hapa. Na mtu wangu Bereje na mwenzangu Dickson Mpama. Tunaimba hapa. Waambie Watanzania wote.
Wakasia bana bati kochema bati kotenderera tipo And a very warm welcome to you. And thank you for joining the WHO NTD department for the next in the series of webinars. Today's focus being on skin NTDs, which are largely prevalent in the world's poorest communities, where they cause long-term disability, stigmatization, and mental health problems. Now, as the new roadmap takes shape, we're very pleased to have had a number of skin experts from within WHO and beyond take part in crafting the conversation today, which we hope will be both robust and informative across the three panels. So a big thank you to you all. As usual, there will be an opportunity for attendees to take part in the discussions through the Q&A option on your Zoom page. Submit your questions, on your page. Submit your questions using Slido by simply entering the event code, which is NTD Roadmap. You can see it on the screen there. You'll need to answer 3 poll questions, after which there will be a prompt to join the Q&A session on Slido. Simultaneous interpretation is also available in French and in Spanish. To activate this function, look to the bottom of your screen for the interpretation pop-up bar from which you can select your language preference. Please note that panelists need to have interpretation off if they have no need for it, so kindly do so now. Now, the NTD, the WHO NTD series of webinars have garnered so much interest, and in the current climate, where more intentional interaction is required between science, research, and the everyday public and the media, I encourage you all to post on social media during and after the webinar. The hashtags to use are Beat NTDs, NTD Roadmap 2030, Build Back Better, and as always, ensure you tag at WHO. So let's continue to make our presence felt. Now, the session today will be live streamed, but I'd like to request that panelists do not click the YouTube link, as it will interfere with the session. So, how does the NTD community tackle skin NTDs to reach the 2030 roadmap targets to reduce morbidity, disability, and the psychosocial impacts? Let's set the stage.
چون قبلا تداوی شده بعدا به اختلاط لشمانیا رفته یا لوپوید لشمانیا میگیمش که مریض یا تداوی ناقص شده یا تداوی منظم صورت نگرفته، بعد از یک مدت طولانی آمده دوباره خود اندفاع میبینیم خود اندفاع فعال است ولی به اطرافش به شکل دانه های خرد و کوچک انتشار کرده کیره به نام لوپوید لشمانیازیس یا یک نوع اختلاط لشمانیاست که تو مریضا را اکثرا زرق لوکل که وقت گرفتن یا زرق از اینا ناقص بوده یا زرق تداوی منظم هفته‌وارشان انجام ندادن، بنابراین به طرف اختلاط یا لوپوید لشمانیا رفتن و ما این بهت مریضا را اکثرا باید تداویشون به شکل آیم یا سیستمیک صورت بگیره که امروز زرقشون مقدار دوایشون نظر به فی کیلوگرم وزن بدنشون میسنجیم که نظر دوایی که ما اینجا داریم سدیم استیبوگلوکونات یا ایسی هست که 20 میلی گرم فی کیلوگرم وزن بدنشون تثبیت میشه. مریضا که وزن میکنیم میبینیم که چند کیلوگرم هست. بالاش رو بچین اینجا مریض 18 کیلوگرم وزن داره. پایش بچین 18 کیلوگرم وزن داره که وزنشون به حساب وزنش 20 میلی گرم میسنجیم. 18 تقریبا 3.5 سی سی. از طریق سی سی این مریضه که خاله جان ما هر روز دستوجیش برای 14 تا 21 روز پیشگاری میکنیم. شما ایره هر روز اینجا بیارین تا که و دیگه این مریضه که کوشش بکنیم که سر اندفاع یا زخمش بپوشانیم که در خانه انتشار نکنه و اگر در خانه کلکین و اینایی که جالی نداره خانه رو جالی بگیرین و اگر امکانات باشه از پشه‌خانه های دوازدگی یا مشبوع شده استفاده بکنین، خصوصا از طرف شب که چون ما در یک منطقه هستیم کجا وفات لشمانیا زیاد است، امکان سرایت از یکی به دیگر داره. اینا در پنجره نداره و این تفلک میشه که چون سالدانه است از با فامیلتان با خواهرش برادرش یا کس دیگه انتقال بکنه، بنابراین در قسمت وقایعی از این بسیار کوشا باشیم که سرایتش به دیگران نرسه.
Giving us a clear picture of the importance of getting the right timely treatment, in this case for cutaneous leishmaniasis, which leads us to our opening question. What and where are the gaps in addressing skin NTDs, and how to improve situations such as the one we've just seen? Let's dive into the first of today's expert panels. With me on this, we've got Roderick Hay, who's the advisor of the International Foundation for Dermatology in London, Giorgio Cometto, head of Human Resources for Health Policies and Standards, Health Workforce Department at WHO. We've also got Victoria Williams, consultant dermatologist and dermatology co-director, Botswana University of Pennsylvania Partnership, and Pauline Kleinitz, technical advisor, rehabilitation program sensory functions at the Disability and Rehabilitation Unit at WHO. Welcome to you all. Roderick, you're conversant with the stats. Third most prevalent cause of illness among the top 10 issues or causes of disability, 10 most common reasons why people seek treatment in hospitals, and more than half of NTDs present with skin manifestations. Can you briefly talk us through the rationale of the integrated skin NTDs approach, Rod?
Yes, thank you very much, Patricia. Can I start by just unpicking those figures? Because what that means is that at any given time point, about just under 1 billion people have something wrong with their skin.
Wow.
Before we get too hung up about numbers, though, we need to recognize that of that huge number, most people present with one of 6 to 7 common diseases. But in addition to that, there are a number of conditions which can affect other parts of the body, but which are manifest in the skin. And that ranges from cancer to autoimmune disease to what we're talking about today, which is neglected tropical diseases. And there is an important group of these, which we call skin NTDs, simply because they present with visible changes on the skin surface. And they range from leprosy to Buruli ulcer to onchocerciasis. So the rationale for bringing these diseases together is very simply that, for instance, many of them are co-endemic. They exist in the same areas. They present with similar skin manifestations. We can use a completely joint approach to detecting cases, to addressing disability, for developing an advocacy strategy, and for also trying to heal some of the wounds, such as the mental and stigma issues. We can share resources. We can use the same people to deliver these programs, and we can double up on community involvement, and we can also address these issues locally, because many of the solutions are relatively simple, so they can roll out at community level. Assessment, that is also something we can do in common, because we're looking at something you can see, and therefore assessing and evaluating your program is relatively simple. We can integrate health systems with this, and this has huge advantages because you can learn things from one disease and then translate it into another. And finally, we use the same support base. So it's a similar group of NGOs, donors, professional bodies who have an interest in these diseases. So there are many, many different reasons for adopting an integrated approach. And I guess as the session evolves, we'll discussing some of the problems and the different ways of dealing with it.
That's right. Thank you. Thank you so much, Rod. Giorgio, you contributed to both the WHO Global Strategy on Human Resources for Health and the WHO Guideline on Health Policy and System Support to optimize community health worker programs. Let's talk around what happens at local level for a moment. Run us through the role that the community workers play in addressing skin NTDs.
Thank you, Patricia, and good afternoon and good morning to all the participants. About 3 years ago, WHO undertook a large-scale exercise to answer exactly that question. What is the role of community health workers and what is their institutional place and require support by health systems. Now, we undertook this exercise admittedly with a different purpose, which was really to identify the policy levers and the system support interventions to optimize the role of this occupational group. So we looked at aspects such as selection, optimal training, licensing and regulation requirements, career management support, and so on and so forth. However, an important incidental finding, if I may call it that, was to also appraise the evidence regarding the safety and effectiveness of community health workers in the delivery of a range of primary healthcare interventions. And while their role may be better known perhaps for other interventions, for other diseases, think of HIV, maternal and child health, immunization, etc., we actually did come across a substantial body of evidence supporting, corroborating a positive potential for the role of this occupational group in the prevention, diagnosis, treatment and care of a number of neglected tropical diseases. Just off the top of my head, I remember seeing systematic reviews and evidence referring to their role in the treatment, in the diagnosis and prevention, diagnosis and treatment of Buruli ulcer, trichiasis, lymphatic filariasis, psoriasis, schistosomiasis, sleeping sickness, as well as others. This evidence, admittedly, is not perfect. Much of it comes from descriptive studies. Much of it has variable levels of certainty and quality. And also, we found comparatively less on preventing and treating yaws, yellow fever, dengue, worm, etc. But overall, while the definition of the scope of practice and therefore the educational requirements and accompanying system support measures is something that should be obviously defined within an individual country, within an individual jurisdiction in relation to the local epidemiologic context and in relation to the place that community workers have within primary healthcare teams. Overall, I think we can be fairly reassured by the evidence that we did find that there is most likely in many contexts an opportunity, a positive potential for community health workers to play a substantial role in addressing these important conditions.
And you're right, you know, really across healthcare, really generally, and especially at community level, there are so many volunteers, and very often they are the data banks, the interpreters, the cultural mediators, and many don't get paid for all that legwork. How can they be motivated in contributing to what they're already doing so well?
Thank you, Patricia. This was actually one of the questions that indeed were at the heart of the whole purpose of the show, developing guidelines on this. We looked at required elements for ensuring the sustainability and the continuity over time, the institutional support for community health worker programs. And while undoubtedly there may be a role for a number of other strategies and incentives, including non-monetary incentives, both from the perspective of the evidence and from a labor rights perspective, the experts that accompanied WHO in the development of this guideline and the WHO Secretariat itself, of course, ultimately went for a strong recommendation that community health workers should be remunerated for their work with a financial package which is commensurate with their job demands, with the qualifications, with the responsibilities, and with the number of working hours. This is not to detract from other important elements. I already mentioned non-financial incentives. There are other elements that relate, for example, to developing possibility for career development, a career pathway. They may see them eventually undergoing further training and graduating to different positions, or perhaps to a senior, more high responsibility position, even within the same occupational group. But overall, it was felt that the evidence points to greater motivation, greater retention, greater sustainability. We didn't really find a lot of arguments against paying community health workers. Obviously, there is a key question regarding the financial feasibility, regarding the affordability of moving on to the recurrent cost, whether it's on the wage bill or whether there are other mechanisms to pay for that. Clearly, there is an issue of financial feasibility in many contexts. And in our mind, that's something that should be addressed as part of a broader conversation regarding the financing of a healthcare system, regarding a prioritization of expenditure. But at the same time, and I'm going to conclude on this point, we also have evidence that when adequately supported, when these programs are adequately implemented, community health workers are indeed a very cost-effective way of delivering primary health care. So it is probably one of the best value for money type of investments that can be made in health systems and in workforce. So somewhere in the budget, it should be possible to squeeze out the resources that can accommodate providing these occupational groups with at least a decent living wage and decent working conditions.
That's right. Thank you so much there, Giorgio. Now, evidence points to the fact that skin NTDs occur mainly at primary healthcare level, where doctors are scarce, Virginia. You've carried out extensive work examining what occurs in low resource settings. Are there any available technologies or tools that can be optimized to support health workers in remote rural areas?
Yes, definitely. So this is a very exciting time for technology. I want to try to discuss both mobile educational tools and teledermatology as methods to alleviate the gaps in care for skin diseases. So mobile educational tools are any type of application or program that you can access on your phone that can support health education and patient care. So in the same way as smartphones have transformed everyday life across the world, mobile educational tools have also the potential to revolutionize healthcare, and particularly for skin disease. So this is because traditional textbook resources for dermatology are often skewed towards information and images that may not be as relevant for skin of color or limited resource settings. In addition, they can be expensive, inconvenient, go out of date. So I really think of mobile educational tools as a lifeline for isolated and overworked primary care providers, who are really the ones serving at the front line of care for skin disease, but are the ones who have the least access to dermatology education or support. So having an educational app on your phone is like having a textbook at your fingertips live at the bedside. But instead of just seeing pages and pages of static reference information, these applications give directed clinical decision support. So what providers can do is enter signs and symptoms they see in their patient and get a focused list of possible diagnoses with example photos, suggestions for diagnostic workup and treatment, which allows them to pick up important diagnoses that they might otherwise miss, like skin NTDs. So I really want to let providers know that they can currently freely access 2 excellent tools in their Android or iOS app stores. So that's the WHO Skin NTD app and the NLR Skin app. So these are available in English, French, Spanish, and Portuguese, and will eventually be merged into a single complementary app with a focus on skin NTDs. What I think is even more exciting is that as technology advances, artificial intelligence can be integrated into these clinical decision support tools, creating the possibility for providers to generate more accurate dermatologic diagnoses simply through inputting a patient picture. So a program called Visual DX currently has this machine learning capacity in combination with a library of over 40,000 images of disease variations across all skin tones.
Wow.
So through support of a Gates Foundation grant, Visual DX has created an offline Android application, which will allow providers, even in the most remote settings without any mobile connectivity, to have access to an AI diagnostic support tool on their phones. So this offline app is currently being piloted in Botswana with a goal of creating content that's tailored to local disease patterns and resource limitations. So providers can participate in creating a tool that best meets their needs over time. So in my experience, Oh, yeah, go ahead.
Sorry, I was actually going to mention about the mobile connectivity and being offline, and that's great. But carry on. Sorry, yeah. I caught you off. I cut you off there, Victoria. Go ahead.
I just wanted to say that in my experience, healthcare workers in remote settings gain an incredible sense of empowerment when you arm them with a mobile diagnostic support tool. So these boost morale by giving them an easy way to continue learning and take better care of their patients. And I really think that this is still a major untapped potential to optimize, to treat skin disease in low resource settings. If I have a tiny bit of time left, I just want to mention teledermatology, which is, it's now become a much more well-known and accepted method to provide quality care when you can't get in-person access to dermatology. And there's a number of examples of long-term successful programs. For example, the BOGO platform that's being used by the RAF network in Mali and West Africa. But there still remains major barriers to widespread adoption of teledermatology, and mainly that comes with the funding and coordination needed to set up and sustain equipment, training, and access to a telemedicine platform. So in remote settings, what happens is providers often fall back on using informal, less secure things like WhatsApp. So I just wanted to mention that there is a newer application called Silo, which is a free messenger service made specifically for secure exchange of health information. And this is a great option for telederm for low resource settings.
Okay, but Victoria, you could probably speak more to that when we go into our Q&A, because yes, we are a bit tight on time. Let me turn to you, Pauline. Strengthening, restoring and developing systems, monitoring frameworks, it's all critical work. How is WHO helping countries to address disability-related issues of skin NTDs and other chronic conditions?
Thank you, Patricia. And I'll answer that question really in two parts, because WHO is moving forward in terms of building more inclusive, accessible health services for people with disabilities. But also then in the second part, really speak to how we are building, supporting access to rehabilitation and assistive product services. So just broadly, of course, WHO is actually in the process of defining an internal disability strategy, which will, really highlight some of those key strategic approaches internally and also programmatically. And we have a disability action plan, which really, it finishes next year, but it is about building inclusive and accessible healthcare for people with all types of disabilities. And of course, people with skin NTDs, but people with a range of different disabilities, because it's a very diverse group of people. And that speaks to one of the ways forward, because while we know, some of the basics about, okay, we need to make services, inclusive, accessible, affordable, they need to be non-discriminatory. It's also really important that we understand, from a health equity perspective, what are those avoidable causes of health inequalities. So there are particular population groups within, the broader disability community that we need to understand better. What are those barriers to healthcare? What are the different facilitators, and of course, how that might vary across these population groups. And WHO is really committed, certainly, to bringing that sort of thinking and building the evidence base in terms of those policy program interventions that do make a difference in terms of access and health outcomes for people with disabilities. Broadly, including, of course, skin NTDs. But then the second part, speaking, I guess, specifically to often those services that are needed by people with the complications, with the long-term implications of skin NTDs and rehab and assistive products in particular. And one of the key ways forward has been certainly ensuring that healthcare and health services, well, ministries of health, even understand that rehab is an essential health service. And that might be quite self-evident, but we really have had to at times promote that. And while you are working in an area of neglected diseases, sometimes we feel like we're working in an area of neglected healthcare sometimes in the rehab sector. So we really have to make sure rehab is integrated into healthcare, that it's part of the prioritising, the planning processes, and of course the financing mechanisms. for people, and whether it's skin NTDs or other, other disease groups or condition groups, rehab and assistive products are really highly integrated types of health services. They shouldn't sit alone in parallel service structures.
Yes.
They really are to be integrated into the care of people, and it's often people with these chronic health conditions, whether it's NTDs or NCDs or older aging or mental health, so certainly ensuring that rehab assistive products are built into the care pathways, the care management, is crucial. And just even what we find is sometimes, a lot of health services are not even good at identifying people with those rehab needs. They don't actually recognise that someone with this health condition would benefit from rehab, and of course know where to refer or, what advise the person. But one of the crucial things for us is that, it's a highly integrated health service, which ideally means it's highly available. But this is often the challenge. And in the countries where NTDs, and particularly some of the skin NTDs, are endemic, these are often the countries where we have rehab maybe at the mostly at the tertiary level, possibly at the secondary level of healthcare, but often very limited at primary healthcare and community level. And as you have said, I mean, this is the level in which we can really change things in terms of transforming the access to these services. So we actually are also moving forward as a program, and WHO is also promoting those task sharing, task shifting approaches at primary healthcare, and with, whether it's the nurses, the doctors, the community health workers, to really develop, those limited sets of rehab interventions and the guidance and the training that goes behind that, so that at least some, often, just a limited amount of rehab can be delivered at that level, knowing that not often people are not going to reach the secondary or tertiary level, but that we can utilize that. And it's interesting, like our previous speaker in Victoria was saying about telehealth services. I mean, I think we've all seen the revolution, and it's on its way and it's here. So these are important ways.
Can I just jump in there and ask about the rehabilitation program and how it's planning to work with the NTD department to advance work in NTDs particularly? Did I miss that?
Sorry, to me? Yeah.
Yes.
Yes, of course. We're working at the moment on an initial. There's an initial. Obviously, it's integrated into the roadmap, but we are moving forward with an initial, almost what I would call like a fact sheet or a thematic brief that is positioning this work. And I think this is the reality, Patricia. I think we're at early stages of good. At a high level of our organisations and programs, really defining those approaches, making sure we're on the same message and on the same approach. And really, of course, this is about integrating and working collaboratively at a country level, right down to at those service levels.
Okay, thank you so much, Pauline. I would like to say that we have a bit more time, maybe a couple of minutes of some follow-up questions for the Q&A. Rod, if I could come back to you, having listened to some of your fellow panelists, what are some of the challenges that you think should be addressed moving forward? If Rod is still with us, I don't see him on camera yet. It seems not. Rod?
Yes, I'm here.
Please turn your camera on. Yes, I can hear you. I don't know whether you heard the question, though.
Okay. No,
did you hear the question?
Repeat it?
Yes. So having heard some of your fellow panelists, what are some of the challenges that should be addressed moving forward, do you think?
Well, I mean, one obvious one is training. Which is, so how do you train people who are not specialists in a field to be able to operate these programs? That's a very interesting challenge. A second one is actually, how do we, we're talking to a group of people who are sold up to this idea but we need to spread it further. We need other people to take on the challenge of integrated disease. Sometimes they're our own colleagues, sometimes they're communities, sometimes they're governments. There's a huge amount of advocacy work that needs to be done, and particularly to try and bring our patients on board with this.
Yes, thank you very much. Now, I will just say a great starting panel, and thank you to all of you and your contributions. You know, Rod, you're talking there about training and advocacy, just a few of the main takeaways there, but let's take a minute or two to hear a few voices from the experts commenting on what is being done, including the WHO Pictorial Guide, which is largely used as a training manual for healthcare workers working with skin NTDs. Have a look.
The new WHO training manual for recognition of skin NTDs and signs of common skin disease was designed for the use of frontline health workers without specialist training in dermatology. We believe that it will provide a method of recognition of these important diseases.
These have been really debilitating diseases which have not received as much attention as the others. And so this is an opportunity to focus on them, bring more attention on them, but to also maximize efficiency.
We also think it would be helpful in terms of advocacy, bringing a dermatological focus.
Some of the skin NTDs can lead to non-communicable diseases like rheumatic heart disease, and they have common manifestation like diabetic ulcers, and they have common management with these other non-communicable diseases or even communicable diseases.
It makes sense where those diseases occur in the same area to use the same infrastructure organization.
Right now we are working in Ghana, Ivory Coast, Togo and Benin, and we are implemented the integrated approach with 3 of the neglected tropical diseases like leprosy, Buruli ulcer and PN. And we are doing this together with national programs and trying to join also the laboratories.
Nous intervenons dans les activités préparatoires de la mise en œuvre de l'approche intégrée, dans la mise en œuvre elle-même et dans les activités post-mise en œuvre. Qu'est-ce que j'appelle activité préparatoire? C'est essentiellement la sensibilisation, la formation des volontaires de village, des infirmiers et de tous les réseaux qui participent à ce dépistage-là.
Thank you very much for that. And, you know, on the subject of advocacy, as we all know, the skin NTDs are not well known, and the Royal Society of Tropical Medicine and Hygiene are working with partners to advocate for this neglected aspect of NTDs as part of this effort. They will be working with the mycetoma community to publish a special issue of their peer-reviewed journal, Transactions on the topic of mycetoma, which they hope to be available for the anniversary of the mycetoma call to action in mid-February 2021. That's some wonderful news there. Thank you very much to RSTMH for that. Okay, so now let's turn our attention to how we can bring everyone working together on this, from donors, government, professional bodies, NGOs. Partnerships and research anchor the next 80 minutes of discussion on how to drive the agenda forward effectively. So joining me for this as well, I have Claire Fuller, who also featured on the video we've just seen, who's the chair and consultant dermatologist at the International Foundation for Dermatology in London. Isra Cruz, head of the International Health Department at the National School of Public Health, Instituto de Salud Carlos III in Madrid, Spain. Christian Johnson, medical advisor at the Raoul Folho Foundation in Paris, France. Chandrakant Travanka, an independent public health medical consultant with WHO and a number of other international and national partners, who's based in New Jersey. And Sahar Bakaid, head of the research unit at the Mycetoma Research Center in the Sudan. Claire, let's start off with you. As chair of the NNN Skin Cross-Cutting Group, how can you see your organization push the skin NTDs agenda forward?
Thank you, Patricia. Well, first of all, I'd just like to say I'm so pleased to be on this webinar and to have shared with the previous webinars, learning how the shift is towards now a priority of the persons and families affected with NTDs, and recommending that one way of achieving this is focusing on integrated cross-cutting approaches. And we learned in the last webinar the importance of inclusion, and that this is a key part of realising universal health coverage. And inclusion for the skin NTD cross-cutting group is a priority goal, reaching a situation where all persons with skin disease in our endemic communities will have access to dermatological care. Our approach to achieve this is by bringing an integrated dermatological focus to all NTD interventions. And we're ardent advocates of the principle that skin health has a significant part to play in global health. So getting back to your question, how can we push forward the skin NTD agenda? Well, the simple answer is by rapidly and appropriately building dermatological capacity, as Rod's mentioned, in areas of need. And in our cross-cutting group, we're doing this in several ways, through strengthening specialist international leadership and influence. And here we look to one of our members, the International Alliance of Global Health Dermatology, or GLODERM, which is a relatively newly convened group of dermatologists with expertise, skill, and passion for NTD dermatology. We're doing it through developing a critiqued and relevant inventory or toolbox of materials for supporting the non-specialist community healthcare workers to diagnose and manage simple skin disease, the educational component that Rod has also referred to. And this includes bespoke teaching and training tools, as well as diagnostic support apps and platforms, which Tori shared so nicely with us in the last panel. We're also working on cataloguing and championing integrated management packages, noting how really simple community self-delivered interventions, for example, for PODO, like involving washing, moisturising and shoe wearing, can benefit other tropical lymphodemas, as well as improving skin barrier function in general, and reducing acquisition of a raft of other NTDs, from snake bite to STH. Increasing access to laboratory support for certain skin NTDs, such as deep fungal infections like mycetoma, is also a gap, which we've heard already, and developing consolidated training documents or tools that can be universally used or adapted regionally to support laboratory technicians and train existing healthcare workers is another identified area for our group to champion. It's been exciting to assist with the production of the WHO guidance document for national programs, which we're about to hear more about. So I'm generally enthusiastic and optimistic about our plans and opportunities for the Skin NTD cross-cutting group to make a significant contribution in accelerating progress on the roadmap targets.
So there's a lot going on there already. Isra, following on from what Claire has mentioned on the possibilities for different stakeholders to play their roles effectively in this, your focus work pivots mainly on innovation and implementation research. Is there any progress in this area to develop simple yet effective tools that can improve field work?
Well, hello, Patricia, and thanks very much. Well, I think that if we want to bring our partners together to fight this, it's important to show them that we have the appropriate tools to diagnose the diseases, to inform where the disease is occurring, and also that we have the right tools for treatment. No? In this sense, I think on the diagnostic side, there is an important taken by WHO, no? For example, and is that the need for better diagnostics for these diseases, and the role in the control programs is highlighted in the new roadmap for neglected tropical diseases. And following this logic, the WHO has convened the Diagnostic Technical Advisory Group for NTDs in order to advise on diagnostic gaps, to address problematic needs, and to develop target product profiles, engaging the R&D community, industry, and other stakeholders in order to develop this solution. And now with a more specific focus on this group, no, that the WHO DTAC has a dedicated group to skin NTDs. For this, there are different diagnostic needs. There are skin NTDs, for example, such as onco or lymphatic filariasis, for which the priority is test for surveillance and monitoring. While on the other hand, there are other diseases such as Buruli ulcer, cutaneous leishmaniasis, mycetoma, etc., that require like better diagnostic tools in order to so, but also not only on the diagnostic component, also on the management side, it has been said, no, the integration of the effort to integrate, for example, the WASH and the NTD program will have a positive impact in wound care and self-care of lesion, but also the inclusion of social research to address stigma and comorbidities. That's also another point for innovation. No? On the treatment. On the treatment side, there have been important breakthroughs, such as the use of single-dose azithromycin for yaws, or in for example, the treatment management has evolved from surgery early in the 2000s to 8 weeks antibiotic treatment with injections of streptomycin, and now it's fully oral treatment for 8 weeks. But still, there are challenges to address there, no? Like addressing resistance for azithromycin for yaws, or trying to shorten in the time of treatment of Buruli ulcers. But talking about innovation, I think it's here it comes the role of public-private partnerships. For example, one of the diseases that lacks diagnostics and lacks proper treatment is mycetoma, and we have a DNDI, the Drugs for Neglected Disease Initiative, working with partners to develop new treatments for mycetoma, and they are also involving in a very innovative fashion, no, virtual drug discovery community. Or we also have on the diagnostic side, we have the Foundation for Innovative New Diagnostics, which who together with other partners are developing RDTs, for example, to diagnose Buruli ulcer at the community level or at the public health center level. No?
Yeah.
I would say that the main goal regarding skin NTDs is to fully materialize the integrated management. And for this, the diagnostics are key. I mean, not only in order to diagnose the disease, but also for mapping and for differential diagnosis. In this sense, perhaps, and this has also been mentioned before, no, this cross-cutting platform or strategies would be very welcome. And there are initiatives in this regard. No, like said now, the WHO starting with this manual on skin for frontline health workers, plus the skin app. But there are also other colleagues, you know, like the Netherlands Leprosy Relief Foundation that has developed another skin app or a mobile phone application for skin disease diagnosis. These are very good starting points, but they need to be supported with a diagnostic test.
Yeah.
So, and always not talking about cross-cutting things. So multiplex or shared platforms, digital image analysis with artificial intelligence. All these are strategies that will be very welcome. No?
Yeah. Well, actually, we're going to be asking Saha something similar, and of course, she works in mycetoma. But we'll get to you, Saha. Right now, I'll turn to Christian and to what NGOs are doing to support the integration of skin NTDs approach. Could you speak to this, and also to what the critical challenges are in scaling up that need to be addressed?
Merci beaucoup. Comme nous avons la chance d'avoir des services d'interprétation, je vais m'exprimer en français.
Yes.
Et comme vous l'avez dit, la Fondation Raoul Foloro est une fondation qui, depuis plusieurs années, appuie des pays francophones dans la lutte contre la lèpre. Et justement, dans cette lutte, nous faisons face à plusieurs défis. Ces défis, c'est essentiellement dans les régions, par exemple, où le nombre de cas a diminué, ou bien dans les régions où on a des difficultés à travailler, ou même dans les difficultés que nous avons actuellement à mobiliser les ressources. Et il apparaît que quand, par exemple, on finance des activités, des campagnes de dépistage, et qu'au bout du processus, l'agent de santé ne dépiste que 1, 2, 3 cas d'ulcère de Buruli ou 1, 2, 3 cas de lèpre, eh bien, l'activité n'est pas efficiente. l'activité n'est pas efficiente et le personnel de santé est démotivé. Et justement, donc, cette approche intégrée est une opportunité de renforcer et d'améliorer l'efficience de nos interventions. Pourquoi? Simplement parce que lorsque vous financez une activité et que au cours de la même activité, l'agent de santé, l'équipe de santé est en mesure de dépister des cas de lèpre, des cas d'ulcère de Buruli, des cas de pian et d'autres dermatoses, eh bien, l'activité devient beaucoup plus efficiente. Et c'est un peu cette approche que nous essayons de développer actuellement au Bénin, en Côte d'Ivoire. Et il est heureux de dire que nous travaillons main dans la main avec la Fondation Anesvad. Et ensemble avec cette fondation, nous essayons de soutenir, donc comme je le disais tantôt, des campagnes de dépistage intégrées où au cours d'une même campagne, on dépiste plusieurs maladies. Nous soutenons également des campagnes de sensibilisation intégrées au niveau des communautés. Nous soutenons également des séances de formation intégrées du personnel de santé. Donc, au cours de la même session de formation, nous allons former les agents pour dépister et soigner la lèpre. Nous allons former les agents de santé pour dépister et soigner l'ulcère de Buruli. Nous allons former l'agent de santé pour dépister et soigner le pian. Et également, nous allons former les agents de santé, les équipes de santé pour dépister les maladies dermatologiques les plus courantes. Et en faisant cela, on augmente l'efficacité de nos interventions, on augmente l'efficience de nos interventions et on augmente également la qualité des services offerts à la communauté. Alors, dans cette vision, je dois reconnaître qu'il y a plusieurs défis. Et au nombre de ces défis, il faut signaler que dans beaucoup de pays, les maladies sont gérées par des programmes différents, des programmes verticaux. Et mettre tous les acteurs ensemble pour pouvoir travailler relève du défi, n'est-ce pas? Si on veut également travailler à l'échelle d'un pays, il faut mobiliser des ressources. Or, chaque donateur veut avoir la traçabilité au niveau de ses ressources. Donc, pouvoir mettre tout le monde ensemble pour dire, nous allons mettre les ressources ensemble pour développer des stratégies intégrées, cela demande des efforts au niveau de tous les acteurs. Et ça reste également un défi. Il y a la question non moins importante du leadership des pays. Pour que cette approche intégrée marche, il faut que les pays s'approprient cette stratégie et essayent de la développer, essayent de la mettre en œuvre. Et également, ce défi-là existe pour que nous puissions atteindre cette stratégie. Et surtout, dans ce contexte où nous sommes actuellement, où il y a une diminution des ressources à cause de la pandémie de Covid-19, par exemple, eh bien, fondamentalement, cette approche intégrée est une opportunité pour tous les acteurs de développer des stratégies beaucoup plus efficientes, beaucoup plus efficaces. Et c'est un peu le défi que nous avons tous à relever. Et nous essayons de mettre nos efforts ensemble avec les autres acteurs pour pouvoir atteindre ces objectifs. Voilà à peu près ce que nous essayons de faire au niveau de la Fondation Rafolro, en collaboration avec la Fondation Anesvad, pour pouvoir relever ce défi de l'approche intégrée.
Yeah. So let's just turn to Sahar now and see whether there's similar challenges that are being experienced in the Sudan, which, along with Venezuela, India, Yemen, has reported some of the highest numbers globally of mycetoma cases. So there has been some concerted effort and work in this particular NTD in your country, Sahar. Can you give us an example of a tool, perhaps, or method you research that is now being successfully used in the field? And likewise, also the challenges in developing such tools in your area of work.
Thank you, Patricia. Good morning and good afternoon to everyone. As you may know, mycetoma in Sudan specifically and generally globally affect the poorest community in remote regions. The affected population usually are of low socioeconomic status, low visibility and low political and social voice, and hence they are neglected. That's why we are in the Mycetoma Research Center had adopted the holistic management approach to decentralize the patient care, improve the disease awareness and advocacy, provide free medical and surgical treatment locally at the village level, and to improve the affected villages' environmental and hygienic conditions. And this approach, we have implemented different methods. Actually, we started by medical and health mobile missions from the MRC to the endemic villages. And before that, we started general research on the area with a research team consisted of different disciplines, epidemiology, environment, and social sciences. And through this mission, we managed to train more than 300 care providers, medical assistants, nurses, and public health officers on different aspects of mycetoma, diagnostic, treatment, and early case detection. And as a result for all this effort, we had established a regional mycetoma center in one of the endemic villages far away from the center, in one of the highly endemic areas in Sudan called Sinar. And this was in collaboration with the State Ministry of Health of Sinar, one of the endemic area. Now at this day, the patients are treated, diagnosed as a center free of charge. For early case detection, we have trained a very big team of medical officers, house officers, medical students, and healthcare providers using a digital pre-designed validated closed-ended questionnaire in a smart tablets or even in the phones, the normal phones. It's called CAPI. It's a computer-assisted patient identifier. And this software was designed specifically for these projects. They just take the data of the patient, the GPS, everything. And when they submit it, the data directly go to the server in the Mycetoma Research Center where we analyze all this data and follow those patients. Besides that, we did a lot of local community involvement. We had several meetings with the local villagers, leaders, community activists to explain our objective and to gain their confidence and support. And we did a lot of or a quite number of health education sessions and activities for early active case detection. These sessions included small group discussions in the villages, school visits for students, and video film watching, interactive open theater drama. This for health education and advocacy. And finally, we did a community environmental improvement campaign. So we did several campaigns to improve the environment at those villages, sanitation and hygiene, to reduce the mycetoma transmission risk. And for sustainability of this project, we had established what is called a project management board. And this was headed by the State Minister of Health and the senior health official in the area. The mycetoma control program also was involved in this, the local village leaders and representatives from the MRC. And now this board is oversees the project implementation, update, problem sharing, and solving. And you have asked me about the challenges. Yes, we faced many challenges through this project. And I can summarize that the three main challenges we faced. The first one is accessibility to the endemic areas. Because in Sudan, in the rainy season especially, the roads are blocked and it is very difficult to reach those patients on those villages. And now we are trying to do many satellite centers through the endemic villages to offer the free medication through the rainy season where we cannot reach those villages. And also we have the problem of the funding. We had limited funding. So we have advocated for mycetoma and we succeeded to gather funding by donation for this project. Still the funding an issue for this project. The last thing is the cultural barrier. And we overcame this by many health education sessions, awareness, and of course, we did a lot of research. We have many ongoing research in parallel with this approach to support our evidence.
Wow, so there's much going on there in the mycetoma community in Sudan. Thank you so much there, Sahar. Let's continue by picking up on some questions from attendees now listening into this discussion, shall we? Claire, one for you. How does, sorry, Chandrakant, I hadn't even spoken to you yet. I'm so sorry. You're very much involved in the drafting of a much needed framework that will give that will guide WHO's work in the integrated control of skin NTDs. It's like a blueprint of sorts. Where are we with this document? And more importantly, how soon can we expect it to be ready so that interventions can move full steam ahead?
Thank you, Patricia. Good morning, good afternoon, and good evening. The strategic framework document will complement the WHO NTD Roadmap 2030 to assist endemic countries to reduce the morbidity, disabilities, and psychosocial impact of debilitating the skin NTDs. And we have just completed online consultation survey by the end of September 2020, and the analysis is in progress. And I'm highlighting some of the preliminary findings. 241 respondents from 58 countries participated in this survey, and the findings are very interesting. About half of the respondents indicated that the integrated skin NTD work is already implemented in some of the in their countries or the projects where they are working already, and most of the respondents are involved in leprosy, Burley ulcer, yaws, lymphatic filariasis, the onchocerciasis, leishmaniasis, and other fungal diseases. And however, the lesser number of respondents, about 11%, involved in mycetoma, the guinea worm, podoconiosis, and tungiasis. Of course, it may be due to the endemic conditions. And more than 70% of the respondents, the favored the integrated activities and in relation to the social mobilization, active case finding, surveillance, the diagnosis, monitoring and evaluation, and supply system, where the integrated activities can be undertaken. But there are less responses on the integration of social stigma, inclusion, surgery, and mental health. It appears that these need more advocacy and further work to emphasize. Then many respondents indicated that opportunities for integration of skin activities are available, but the challenges are to be solved. The one is the political commitment in a different countries, and the necessary guidelines, how to go about it, and important the coordination between the various sectors and the government and so on, and the funding, etc. We hope the framework document should be ready by the end of December 2020.
Did you say the end of this month?
Thank
I didn't
you so
hear
much
that very
for
well.
your kind attention.
Did you just mention that it was at the end of this month?
End of December 2020.
End of December.
Yes.
Wonderful. I'm sure that will be, people will be eagerly awaiting that. But political will, and you're right, is so important, but we'll be getting to that in our next topic. If there are any, in our next panel, if there are any more questions, let's see. Claire, let's just come back to you. How does the skin group work with the NNN DMDI cross-cutting group to ensure holistic care of patients? This is obviously picking up on what Sahar was mentioning about holistic management approach. Claire?
Yes, well, thank you for that question. And it's a really good one. And one of the things that we've been quite careful to think about and act upon. And we have several, well, certainly we try and populate appropriate work streams that each of our cross-cutting groups develop so that we can make sure we've got relevant expertise on them. So, for example, there's a self-care wound group that's looking at developing guidance and how we might address that, set up by DMDI, but we try and have representation on that from the skin cross-cutting group as well. So joint initiatives, I think, would be the way we're working together, and we are cross-fertilizing our membership quite well anyway to make sure that we pick up on these appropriately shared cross-cutting themes.
Yeah. Thank you very much. Isra, a quick question for you as well. What partnerships are required to accelerate the progress to develop new diagnostic tools and tests? And having the tools is one thing, but getting them to the patient is quite another. What other priority research should be prioritized?
Well, I think that I will not say having the tool first and trying to implement it later. No, I think we need to work from the beginning with the end, or with let's say the context in which we are going to apply the tool in mind, right? So I think that this is something that is covered in this strategy by the WODI, which means let's try to understand which are the programmatic needs. Then let's think about the use case to address this need. Like, for example, where do we want to do the diagnosis of the disease? How and who is going to perform the test? With this information, we develop the target product profiles. And the idea is that these target product profiles will, I mean, the development of these TPPs will involve a number of stakeholders, from people working in the field, which are working day today with the disease, from people working in the industry that maybe they don't have any idea about what's happening in the field, but they have the knowledge and they have the ideas to answer our needs. No, so I would say that the most important aspect here is trying to understand what is the need, the real need in the field. No.
Okay, okay. Thank you, Isra. Christian, over to you. How can NGOs that are dedicated to one disease be able to raise funds to support the integrated approach which deals with multiple skin diseases, do you think?
Oui, encore une fois, je vais m'exprimer en français. Effectivement, la question de l'adaptation des ONG qui sont déjà dans une approche purement verticale à l'intégration constitue un réel défi. Un réel défi, pourquoi? Parce que ces ONG sont déjà habitués à travailler sur une seule maladie, ils utilisent leurs procédures, ils utilisent leurs supports et c'est difficile pour ces ONG de basculer vers une approche intégrée. Mais comme je le disais, l'approche intégrée a une réelle opportunité. Pourquoi? Simplement parce que aujourd'hui, nous sommes tous confrontés à la baisse des ressources. Donc, quand tu vas dire à un donateur, avec les ressources que tu me donnes, je peux à la fois dépister la lèpre, l'ulcère de Bureli, le pian et les dermatoses, eh bien, c'est une façon d'utiliser les ressources avec efficacité et efficience. Et c'est justement dans cette approche que ces ONG devraient travailler, mais surtout en étroite collaboration avec les pays. Il faudrait à tout prix que les ONG ne se substituent pas aux pays, mais favorisent le leadership des pays et puis les appuient pour ces résultats.
Thank you so much there. And thank you to all our panelists and for the additional attendee questions. That is all we have time for in our Q&A. The recurring key points on integration, affordability, availability and adaptability, with active advocacy, of course, at all levels to really bring about the necessary momentum needed. A message I think that NDI know very, very well. Let's take a look. Moving from the wider stakeholder space towards the in-country work, ways to maximize the efforts and impact there. ensuring the surveillance and interventions for skin NTDs are firmly situated within overall Ministry of Health UHC strategies. For this conversation, I welcome Yves Barogui, Medical Director at the Baruli Ulcer Treatment Center in Lalo, Benin, Julian Trujillo, Coordinator, Department of Re-Emerging and Neglected Tropical Diseases in the Ministry of Health and Social Protection in Bogota, Colombia, Murad Mokni, Head of the Dermatology Department, La Rabta Hospital in Tunisia, and we've got Prima Josephine, who is a Deputy in the Leprosy Department at the Ministry of Health in Jakarta, Indonesia, Aya Yajima, WHO Regional Office in Manila, based in Manila in the Philippines. I welcome you all. A question straight to you, Eva. You've played key roles in promoting the integrated skin NTDs effort in Benin, being part of surveys pioneered in both Benin and Cote d'Ivoire. Take us through some of the critical lessons learned, including whether the surveys carried out can be adapted to other countries.
Et bonsoir à tous. Merci beaucoup. Effectivement, depuis 2015, au Bénin puis en Côte d'Ivoire, nous avons commencé l'expérience de l'approche intégrée de la lutte contre les maladies tropicales négligées à manifestation cutanée, notamment le dépistage intégré de l'ulcère de Brûlis, de la lèpre, du pian et de la filariose lymphatique. Pour mener cette activité, nous l'avons mené avec plusieurs équipes. Il y a l'équipe du docteur Aboua de la Côte d'Ivoire, et l'équipe du docteur Ri du Japon et l'équipe de Bénin dans laquelle je suis. Alors, quelles sont les principales leçons que nous avons eu à apprendre? Alors, au cours de cette expérience, nous avons examiné 16 724 personnes qui avaient des lésions cutanées. Tenez-vous bien, seul un cas sur 10 avait des MTN cutanés. Les autres avaient des infections, des autres affections cutanées qui n'étaient pas les maladies tropicales négligées. Alors, quand nous prenons les maladies tropicales négligées à manifestation cutanée, plus de la moitié avaient la gale. Nous avons eu aussi quelques cas d'ulcère de Brûlis, quelques cas de lèpre, quelques cas de filariose lymphatique, quelques cas de pian et quelques cas de mycéto. Les autres affections cutanées qui n'étaient pas MTN, c'était majoritairement des eczémas et des infections fongiques. Nous avons eu l'occasion de réaliser une cartographie intégrée des maladies tropicales négligées à manifestation cutanée dans ces deux pays pour des activités de mise à l'échelle. Alors, pouvons-nous vraiment adapter cette expérience dans d'autres pays? Oui, nous pensons que cette expérience menée au Bénin puis en Côte d'Ivoire peut être adaptée à d'autres pays, mais il faut tenir compte du contexte de chaque pays. Mais il y a quelques préalables. Premièrement, nous avons besoin d'un protocole standard de mise en œuvre, mais aussi nous avons des défis à relever. Souvenez-vous, je disais tantôt que nous avons eu peu de cas de MTN cutané et de nombreuses autres affections cutanées. Beaucoup d'autres étaient faciles à traiter. Cependant, les défis restent. Les défis sont premièrement, où trouver les médicaments pour traiter tous ces cas? Comment les rapporter au système national de surveillance sanitaire? Comment confirmer les cas difficiles de ces maladies de peau? Comment confirmer ces cas difficiles? Comment organiser le suivi de ces cas? La question se résume à comment adopter une approche holistique des maladies de la peau. Plus précisément, comment organiser et promouvoir le renforcement de capacités des agents de santé périphériques sans les surcharger? Comment allons-nous organiser la surveillance des maladies tropicales négligées à manifestation cutanée et des autres maladies cutanées? Comment les prendre en charge? Enfin, pensons qu'il est très important, dès la phase de planification, d'impliquer toutes les parties prenantes clés, notamment la communauté, les leaders, les agents de santé et les partenaires. Et il faut aussi l'engagement des États. Je vous remercie.
Yeah. You're right. Now, like Eva, you have also conducted studies to identify skin NTDs in Colombia, Julian. Tell us about the diseases that you came across there and how you overcame the inevitable challenges you must have faced in your work, given that it was primarily in remote rural areas.
Gracias, Patricia. Buenos días. Sí, efectivamente, en la Amazonía colombiana reconocemos la tungiasis, la escabiosis, la pediculosis, la larva migrans cutánea, la miasis, entre otras, como problemas de salud pública y como que necesitan intervenciones y son necesidades sentidas por la comunidad. Efectivamente, en el contexto donde hemos realizado estas intervenciones, pues digamos hay muchos desafíos, por ejemplo, la dificultad de acceso geográfico, la falta de carreteras, altos costos operativos, barreras de comunicación por la alta diversidad lingüística, inexistencia de estrategia de atención primaria en salud, pocas personas, personal de salud escaso en las áreas rurales, falta de conocimiento del personal de salud en estas áreas. Entonces, no obstante, hemos hecho un esfuerzo y con recursos que ha puesto el Ministerio de Salud y Protección Social durante 4 años aquí en Colombia, esos recursos eran destinados específicamente para implementar la estrategia SAFE de tracoma y aprovechamos esos recursos y esa logística para capacitar personal de salud que visitaba las áreas rurales y para integrar acciones específicas para trabajar sobre la prevención y la promoción de las enfermedades parasitarias que les mencioné y también la desparasitación antihelmíntica. Entonces, durante esos 4 años lo que hicimos fue organizar una serie de protocolos de atención. Creamos material educativo accesible para personas que no necesariamente son profesionales de la salud, con un énfasis en diagnóstico y en tratamiento. Estandarizamos los instrumentos para la recolección de la información, compramos medicamentos, realizamos talleres de capacitación al personal. Una vez hecho esto, conformamos grupos de trabajo que visitaron las áreas endémicas. En esos grupos de trabajo procuramos que hubiera personal local, bilingüe, que conociera la cultura, la lengua, que tuviera fácil acceso a esas comunidades y simultáneo a la medicación masiva con acitromicina para tracoma y a la desparasitación, hicimos un diagnóstico casa a casa de las enfermedades parasitarias de la piel y su tratamiento. Se trataron también los perros y todos los reservorios, digamos, animales de algunas de estas enfermedades como la tungiasis. Se promocionó la higiene facial, la higiene en las viviendas. El tema, se hicieron incluso intervenciones con fumigación, con piretroides, en donde había viviendas con personas altamente infestadas. En el caso de escabiosis se trataba al núcleo familiar de las personas, no solamente a la persona enferma. Y bueno, un tiempo después tuvimos la fortuna del acompañamiento del doctor Hermann Feldmeyer de la Universidad Charité de Berlín, y él nos acompañó en este proceso, nos consiguió y nos enseñó a utilizar la dimeticona para el tratamiento de la tungiasis, nos facilitó y nos donó microscopios digitales para mejorar el diagnóstico de escabiosis y entrenamos personal de salud en varios departamentos de la Amazonía colombiana y pues ha sido en ese contexto de las intervenciones con estas estrategias que hemos podido desarrollar algunas investigaciones operativas pues que nos han ayudado mejor a entender la enfermedad, estas enfermedades.
I think there's detailed work there. And I think an indicator on how much can be done in rural areas with the support of government there. Thank you so much, Julian. Along with being a co-author of WHO's guidelines on the management of leishmaniasis for WHO's EMRO and Euroregion's Murad, you've also carried out an assessment of skin NTDs in the Eastern Mediterranean region. I like what we're doing here. We just seem to be going across. What are the main skin NTDs in this region? And from that, what kinds of integration can be promoted around them?
Thank you very much, Mrs. Patricia. I have did a report for the Emro region on skin NTDs in collaboration with Professor Afif bin Saleh, which is my colleague epidemiologist. And we did mainly, and I thank also all the NTD department in the Emro region in Peru, who give me the opportunity to make this report. This report mainly it's two parts. The first part we tried to review the medical literature, the data available in WHO and other resources, and to see the burden of the skin NTDs in the region. Yeah. And the second part, we did a survey, an online survey questionnaire with many for all country, with the stakeholders of this country, which is interested in NTD, to see the opportunity of the potential of the integration of management, surveillance, and controls of this disease in this country. And obviously, we crossed 8 diseases: PKDL, cutaneous leishmaniasis, scabies, leprosy, mycetoma, fungal disease, lymphatic filariasis, and onchocercosis, with 22 countries in the Emro region. And to respond to your first question, of course, there is an under-reporting like we expect. Yeah. There is a lack of data, yes, but we reviewed at least 1,215 publication, which is almost the distribution of the publication, the scientific and medical publication, which is in agreement with the burden of the disease. And we see that the highest burden in this region is, of course, cutaneous leishmaniasis. And there are, I think, many successes in management and control of leprosy, and also there are successes of elimination program of lymphatic filariasis and onchocercosis. Yes, in some, unfortunately, for some countries like Djibouti and Somalia, we have almost no data. And there are also limited data in mycetoma, scabies, and fungal disease, which we know by the field and by some publication. For example, like Dr. Yves said, there is an iceberg phenomena for scabies and fungal disease, which there are very, very frequent disease, but almost no reported disease, especially scabies and fungal disease. This is mainly for the first part of your question. The second part of your question,
what kind of integration can be promoted? Yes.
Of integration, there are many gaps, challenges, and opportunity. But to be brief, the main challenge is the weakness of the surveillance, prevention, and the health education, the cost of the drugs, of course, and the stigma related to skin NTD. But there is also opportunities. There is a presence of a node surveillance and control program for at least cutaneous leishmaniasis and leprosy. That means we can use this classical program. There is also the availability of school health programs. There is some small pilot integration program in my knowledge in Sudan and Yemen. And the main recommendation here for the integration, we can see from the 22 countries, there are almost 5 clusters of countries. There are mainly the Gulf countries in the region. They have a very low burden of skin NTD, but there is 3 other clusters. The cluster 1 is maybe we can distinguish 4 countries where integrating of multiple skin NTD management plan with the 8 diseases, it's I think possible. And the cluster 1, which is 5 countries where we can integrate cutaneous leishmaniasis, leprosy, scabies, and fungal disease. And finally, the third cluster with 8 countries, we mainly can integrate cutaneous leishmaniasis, scabies, and fungal disease.
Thank you.
Yes.
It's, you know, this whole integration is obviously a big topic here. And going over to Indonesia, let's talk with Prima here. It's the 3rd highest number of new leprosy cases there after India and Brazil. It also has the main endemic country for yaws in WHO's Southeast Asia region. Both the yaws and the leprosy programs, of which you're part of, are run by one unit that allows better coordination, resource sharing, and integration of activities. I'm certain that there are some pertinent lessons that you can share with us in terms of the benefits and challenges here, Prima.
Thank you, Patricia. Good evening to all of you, everybody from Indonesia. So NTDs is commonly known as a group of diseases that begin in the end of the road. Most of diseases, including leprosy and yaws, have been pushed into very low level of prevalence or cases. In Indonesia, we have eliminated leprosy as a public health problem at national level in 2000, while we recorded 673 confirmed yaws cases in 2019. From program perspective, this achievement sounds great, but at the same time, it would also be a challenge in building partnerships with a private sector in NTD's area of work. Our country has committed to eliminate and eradicate skin NTDs. We have allocated more than $2 million each year for leprosy elimination program since 2016. In order to amplify the impact of program and optimize the value of money or resources, we have tried to integrate both leprosy and yaws activities in the field, including first, activity case finding in general population or community and school skin screening. This activity can be used for early detection and prompt treatment if we find suspected or confirmed cases in the field. In Indonesia, we have a campaign called Let's Find the Pets and Ulcer. This is an integrated case finding activity for leprosy and yaws in school and community. The inclusion of leprosy and yaws program in school health program will also provide opportunity to reduce the pediatric leprosy cases, to prevent disability due to the diseases, and to control the spreading of yaws in children and wider population. The National Leprosy and Yaws Program has been working closely with our colleagues from Family Health Unit in Ministry of Health and the Ministry of Education to include screening in health school program. The next is for advocacy and socialization of program for key stakeholders at subnational level, which is very important in decentralization system in Indonesia. And the other activity, integrated yaws and leprosy, is development development of integrated health information system for both leprosy and youth program to ensure timeliness and completeness of reported data from subnational level. So there are also some aspects that should be improved in terms of program integration.
Yeah, could you just name those off quickly so that we can get Aya in there as well and get some questions in? Thank you.
Such as a collaboration and coordination between directorates of health services for improved patient care involving directorates of disease control and prevention, pharmacy and health appliance, National Institute of Health Research and Development, and National Health Insurance System. And the other is facilitate collaboration with Ministry of Public Works to improve sanitation by increasing water supply, or we call it WASH activities, wherever appropriate. Yep. And engagement with private hospital, clinic, and dermatologists. We observe that some leprosy patients, especially they who live in upper middle socio-economic level, prefer to seek treatment from private hospital or clinic to avoid stigma. It could increase the engagement and collaboration with private sector, and we believe that the case finding rate can also be increased. And the last is sustaining commitment and financing from different levels of government, especially the commitment from local government to ensure priority to elimination of leprosy and eradication of youth. We are also currently incorporating the indicator of the proportion of pediatric leprosy cases among new leprosy cases into the indicators of child-friendly cities, which are being processed into the presidential decree.
Okay.
That's all.
Thank you so much, Prima, there. Now, Aya, we've heard much mention of remote areas today and really navigating Vanuatu with 80 small islands that fall under the WHO Western Pacific Regional Office seems to top it all off, to be honest. Yet there has been integrated interventions for yours, scabies, deworming, and non-communicable diseases in place there for some years now. How has this combination worked for you in Vanuatu? Very quickly, in the next 2 or 3 minutes.
Thank you for asking. So I'm speaking on behalf of the Vanuatu team today. So Vanuatu has had a long history of the community outreach activities, starting with the MGA in 2000, and it continued on until now for various NTD on annual basis. So the government and the national provincial team has a very strong capacity and also the platform to reach out to the communities. But slowly, because of the long history of the MGA, so countries started to observe that people are now slowly not wanting to participate in MGA, which we often call MGA fatigue. And also, Vanuatu, many communities have a very traditional way of life, but then they are more and more exposed to the social media, internet, and they are more modernized, and transport also improves. So people moving to the urban areas. So it has also been very difficult to collect people in the village. And in the meantime, so they also realize that the burden of NCD is increasing, but then the awareness of NCD is not really high, still very low in rural communities. So because of all these components, so they decided to come up with the idea of integrating MGA for youth, but integrating with scabies screening and also the deworming for children, together with the screening of NCD and also health awareness campaign, so that the community can receive one, the multiple package of public health services at one time. And so there was a lot of challenges because the different programs have to work together. All the training material and retraining of the health staff have to be redone. And also, so both teams have to understand what the other team is going to do in the field so that they can support each other and they also identify which component will be funded by which program. So all this coordination really require very strong commitment to make this happen. But after all these challenges, but then the program really made a very successful MGA, integrated MGA campaign. So they reached over 95% coverage. And then we also did an interview with the community members because we wanted to document this experience in the video. And then community and even the health staff really appreciated this opportunity, and community especially appreciated because they don't have a tradition or practice of going to the health center to do the regular health check.
Yeah,
the first time they do NCD height, weight, and blood test and blood sugar level testing. So all these health services is as one package in their community. So everybody really appreciated. So we felt that this can be a very good model, not only of the information across NTDs, but also beyond NTD.
Okay, thank you so much there, Aya. Now, so just limited time, so I'm going to do a quick 5-minute Q&A with you all. Eve, a question to you. How can integration of epidemiology, skin NTDs, get to the grassroots in villages, in the community where most of disability are believed to be mysterious? How can integration of epidemiology, skin NTDs, get to the grassroots in villages and in the community where most of disabilities are believed to be mysterious?
Oui,
a deep thought there, Eva.
C'est pourquoi j'avais parlé au début de l'appropriation des États. Il suffit de ne pas stigmatiser.
Yes.
C'est pour ça que j'ai parlé de l'appropriation de l'État, de considérer les maladies tropicales négligées comme les autres maladies et les intégrer dans le système sanitaire. Et automatiquement, depuis la base, chaque cas sera noté et comme ça, on a une vue globale au niveau national. Voilà un peu ce que j'ai à dire. Je sais pas si
Okay, Aya, question for you. How do we get the ministries of health to address skin diseases or skin health as a package as part of UHC? Aya, did you hear that question?
Sorry, can you repeat again?
Yes, I will. How do we get the ministries of health to address skin diseases or skin health as a package as part of UHC?
Well, so as I mentioned earlier, so Vanuatu has a long history of NTD intervention, and they have been very successful. LF has been eliminated, and trachoma has been already submitted for dossier for elimination. So they will now need to move on to the next NTD. So that's, and then the next priority NTD was naturally skin NTD. So they have a high of your scabies. So naturally had this very strong commitment based on their strong experience in the past.
Okay, thank you so much. Really, I must apologize for all the limited time we seem to have overrun because there was so much information to share from all the experts on the panel on this session. But I thank you all for your thoughts, your insights and knowledge sharing. Let's take a brief moment to take in the importance of participation, particularly between the community and healthcare workers in this next story about early detection.
People must know that brulee ulcer is a normal disease which is not caused by witchcraft, a curse, a black magic. People must know the early symptoms of brulee ulcer and report to the hospital because early detection of brulee ulcer is the key to prevent disability and other related problems.
Brulee ulcer, when detected early, can be cured using combination antibiotic therapy for a period of 8 weeks. Community participation is crucial to improving early detection of the disease. Close collaboration between village volunteers and health workers ensures timely treatment of patients and greatly increases chances for complete recovery.
If you go to the hospital early, we can get treated so fast in order to avoid disability. They will go without complications like what some of us pass through.
I think we got cut off there for a minute, but that's okay. Now, for all the challenges faced, a game-changing success story can certainly deliver the ripple effects needed for the many people suffering from the burden of living with NTDs. So it is very good to have Oriol Mita join us today. Oriol, you discovered azithromycin for the treatment of yours. treatment of yours in Papua New Guinea more than 80 years ago. This discovery made WHO's arguments ever stronger to restart the global eradication of yaws. But beyond this, how have you, or you have also been involved in skin NTD work in Papua New Guinea and elsewhere. What are your reflections on moving forward with the skin NTDs?
Well, in 2017, a group of scientists led by the WHO NTDs department wrote an article in the PLOS Neglected Tropical Diseases entitled Integrated Control and Management of Skin NTDs. Some of them are speakers today in this session. And since publication, integration has become a core concept in the public health agenda of affected countries. And only this is a significant milestone in terms of advocacy and research mobilization. So at that time, we identified that it is possible to deploy integrated delivery of healthcare interventions to increase the cost effectiveness and expand the coverage, but also to reduce the delays in diagnosis and associated morbidity. So in PNG, for instance, we identified that there was overlap of diseases where we had villages affected by yaws, some by burroid ulcer, filariasis, lymphedema, and also scabies and tinea. And our village workers or community healthcare workers could diagnose all these diseases and treat them at the point of care. So since 2017, what has happened, the multiple pilot projects have been implemented all over the world, mostly in Western Pacific, Papua New Guinea, Vanuatu, where we conducted mass drug administration, so preventive chemotherapy for multiple diseases like yaws, integrated with filariasis or trachoma. But also in 2017 and 2019, Cote d'Ivoire, Benin, and Liberia ran programs where the health workers were trained for identification of skin NTDs and showed successful results. So this session shows the progress that has been, these webinars and the speakers have shown the progress made since 2017. Before 2017, no one talked about skin NTDs. Wow. Today, we spoke about the feasibility, the partners required, and the multiple packages to operationalize the implementation of skin NTDs program. So in terms of feasibility, I think that it is clear now that it's financially feasible and highly cost effective, and that community health workers can be given a good salary package. But also there are supporting tools like the mobile education tools and the teledermatology, and there has been progress made on the side of long-term implications, and these are the rehabilitation services and management of disabilities. But our speakers have talked about the partnerships that are required to work on different areas, for instance, building the capacity and the development of educational tools, but also strengthening the leadership at the country level, someone that takes the lead on the skin-related tropical diseases. And they have spoken about the research partnerships and the need for better diagnosis and progress on treatment. Those diagnoses are rapid diagnostic tests, but also digital tools or multiplex LAMs, for instance. And finally, we learned that there is NGOs working groups that still having challenges to move from the vertical and traditional implementation to this transversal and holistic approach. So to end with my wrap up, I'm happy to see that packages have been developed. For instance, the skin health as a package with the standard operating procedures. It's now part of some ministries of health, but also resources are being put aside to implement programs. Reminder that skin NTDs occur in rural areas with lack of roads and healthcare workers. And researchers are so important. And interesting implementation of the MDA in Vanuatu, where training and retraining of staff was critical.
Oriol Mitya, Associate Professor at the Hospital Germain Tria y Pujol in Barcelona, Spain. Thank you for joining us. And if I could invite you in at this point, Dr. Muele, The success of NTD programs has been viewed as a means to achieve universal healthcare. Earlier, you mentioned skin NTDs being the most neglected of them all. Now, given the various panel discussions that have taken place today, with numerous guides and frameworks being put in place, what are your thoughts on all the impressive work being done and the impact this will add to the roadmap, of course?
Oh, thank you very much, Patricia. And it was a wonderful afternoon of a lot of insight on skin NTDs, which are half of the 20 NTDs and affecting they're a leading cause of stigmatization, discrimination, prejudice, social alienation. And like one of our colleagues said, they begin at the end of the road. Yeah. So the skin NTDs, like has been said several times, require a holistic multisectoral approach in order to address both the physical and psychological impact. They require strong health systems. And that's why the roadmap with its 3 fundamental shifts are key, and I believe a great opportunity for the skin NTDs. And why do I say that? So there is a strong rationale for integration. Everybody spoke about the importance of integration and how we can integrate at various points in the skin NTD continuum. We can talk about diagnostics in an integrated fashion. We can look at training. There are technology options. And then, and the second part of the roadmap shift, which is multi-sectoral action, there is more than just health. We need to go beyond health. We need to be thinking about WASH and its impact on skin NTDs and the importance of it on skin NTDs. We need to look at education and other such factors in the context of skin NTDs. So I look at that third shift, and then I finally look at the country ownership. And that's been discussed a lot, because at the end of the day, these interventions have to work at the local level. They have to work at the national, they have to work at the subnational level. They have to work in that context. And all these issues that we're talking about, affordability, accessibility, and availability, have to be in the context of the country level. And so, the data and data availability and the use of data for decision support, all these things have to be at the country level. And so I think when you tie this all up, it really makes a very good combination for the skin NTDs, that the shifts in the roadmap really support the push for this integrated approach to skin NTDs. And so I'm very impressed that we've had a really good discussion today. And as we know, the skin NTDs have been far too long neglected. And if we are to reach the 2030 targets, then we have to focus on this integrating our efforts, as well as the care and as well as the research. And this will have to be done from the ground up to ensure quality care to the communities they impact. I want to thank everybody, Patricia, and particularly you, and to thank everyone for their passion and commitment that has brought us here today. As our colleague just said, in 2017, that's when this discussion began. But I am so excited to see now that it's an integral part of the roadmap moving forward. And so I thank you and wish everyone a good afternoon.
Dr. Mwele Malechela, Director of the Department of Control of Neglected Tropical Diseases at WHO. Thank you so much for your thoughts, informative and enlightening discussions, and I'm sure the conversation will continue in earnest even whilst this webinar session comes to an end. It's all about keeping up the momentum on the work around all NTDs. Remember, our next WHO session will be on the 18th of November. Save the date, as the conversation will look at optimizing One Health and the global vector control response to reach the 2030 NTD roadmap goals. I look forward to seeing you all then. Stay safe for now and enjoy the rest of your day. Thanks very much. Bye-bye.